Welcome to This Just In, the show bringing you the latest advancements in healthcare, strategy, innovation, and public policy. And now, for the fastest voice in healthcare, here's your host, Justin Barnes.
Thank you for tuning in, and welcome to This Just In. I'm your host, Justin Barnes. In these segments, I'll bring you the latest advancements in healthcare, strategy, innovation, and public policy. As always, we're broadcasting from the This Just In studios on the Business Radio X network, as well as the Healthcare Now radio network. For this episode, my 215th episode, we have a follow-on show here, and very fortunate to have two healthcare pioneers and leading healthcare authors, Dr. John Halamka and Paul Cerrato. Welcome back to the show, gentlemen.
Thank you.
It's always great to have you.
Thanks so much.
You got it. You got it. And we're here to discuss your new book, The Digital Reconstruction of Healthcare, Transitioning from Brick and Mortar to Virtual Care. And I know this is on, if it's not, it should be on the top of mind of everybody in healthcare. I mean, certainly as a provider, as a healthcare organization, but certainly as a patient, because our worlds have changed tremendously on how and where and when we engage providers in healthcare. And so I'm excited for this show. It's a great book. I'm able to see most of it. And the first show was fantastic. We left a great cliffhanger on virtual care and in which you guys see some of the evolutions here. But before we dive in to our second show here, John, where are you calling in from, my friend?
I am in Sherborne, Massachusetts at Unity Farm Sanctuary, watching the ice get a little bit more liquid, but just wait a few hours, it'll get solid again.
And how many animals do you have around you right now?
So there are 300, but since the snow is still about 24 inches deep, I don't have the usual ducks, geese, and guinea fowl outside my office window.
That's so cool. If everybody has a chance, please do check out the Unity Farm Sanctuary. They're on all the social platforms. I watch some of the live streams, but it's just a blessing. Dudley's a good friend of mine. I actually need to re-up my support for him and his feed, because you take obviously support from communities, correct? And as individuals.
Yeah, and so we are a 501c3 charity, and so all the animal care, medical care, and food is all charitable.
Yep, I need to get my part back in there. It's great therapy. So I love to personally see it. Paul, where are you calling in from, my friend?
I'm in upstate New York in a town called Warwick, about 60 miles northwest of New York City, where we got about 2 feet of snow, maybe about a week ago. So I'm still digging out.
Excellent. So we talked about really some of the advents of virtual care and even some of the major tenets that we see as innovations. You brought up the term navigators, which I completely agree, because there's certainly a chasm out there. Virtual care is a very complex topic. And a lot of institutions, when I get out there and I speak with people, they're not sure where to start, or also their definition of virtual care is very different. And there's nothing wrong with that, but this show I like to use as a medium to offer best practices, strategies, blueprints for success. So again, if you didn't hear the first episode, please tune into that. John and Paul lay out some great tenets of where to get started and also what to look out for. We've dove into a little bit of AI, which is usually a big topic in machine learning, but also some ways to successfully manage that and use AI and implement it in machine learning. But now let's dive into telecare, telemedicine, telehealth. First of all, are there any differences? We're using different terms because I've heard us even on our last show mention it different ways. I'll say telemedicine for the sake of this immediate conversation, but I'd love to know first of all, do you see any differences there, or is it just different use of terminology? What do you think about that, John?
Well, so of course, if you study Greek, right, we're just talking about at a distance, right? Mm-hmm. And so the question is, what is telehealth? What is virtual care? If I send you a photograph of a mole and say, is this cancer? Oh, well, that's a kind of diagnosis at a distance. Mm-hmm. If we have a virtual visit that is a Zoom, a Teams, a meet encounter that is similar to what we would have done in person, it's just at a distance, well, that's a virtual care or telemedicine episode. What about remote patient monitoring and a high acuity, serious and complex hospitalization in your home? Well, again, it's a different kind of telecare, but certainly one that's really important as we look in the COVID era. Do you really want to go to a hospital which might have infected patients in it if you're a immunocompromised person needing a serious and complex intervention. Well, you'd probably rather get that in some alternative location. What about EICU? Control of ICUs from across the country. And Mayo often does that. So I would just tell you, when we talk about telecare or virtual care, it really is a spectrum of activities.
Excellent. So diving into telemedicine, telecare, it has taken off since the advent of the pandemic early in 2020. But from your perspective and some best practices that you can offer, what are some of the strengths and weaknesses that you see?
One of the things we talk about in the book is the tremendous variation in the quality of care of some of the telemedicine services. Probably one of the most worrisome reports I've seen came out in JAMA a couple of years ago, spearheaded by a doc named Jack Resnick. And what he and his colleagues did was they looked at several direct-to-consumer dermatology services. And John just mentioned how it's possible to diagnose skin cancer by looking at a mole over the internet, which is fine. But this study looked at several different services and found that there were several missed diagnoses, and some of them were pretty serious. For example, they gave me one patient who had secondary syphilis was misdiagnosed. Obviously, you don't want to miss something like that, since it could be life-threatening. So once again, there's a tremendous variation in terms of the quality of care that you can get from these types of services.
So, John, what are some of your thoughts on where people can start, and a lot of them have started? I think on our last show we talked about how 90% of care was through telemedicine in the early advent of the pandemic, and now we're stabilizing around 20 to 25%, depending upon specialty and community and other factors. But what are some of the strengths that we can, that you can offer out there to get people started, or how to engage, or how to be, just be better in this area?
Yeah, so one of the questions you should ask as a healthcare organization is, what are your assets, so to speak? Is it that you have lots of bricks and mortar, you have lots of clinicians, you have lots of IT experience? What are the things you have that you want to leverage? Well, here's one of the things that we've found, especially in community sites. They don't actually have a lot of spare space. They don't have capital to go build a new OR or a new set of beds, and they may not have a vast amount of IT resources. So we have clinicians, however, that can expand their scope of practice at a distance. And in fact, maybe you can use your existing staff to see more patients if you just simply then use a telemedicine service of some kind. And again, that might be outpatient, or it could be this more serious and complex care. And I reflect on this because as Mayo Clinic launched its advanced care at home, we launched in two marketplaces, Florida and Northwest Wisconsin. And what we found in Northwest Wisconsin is the hospitals there had the clinical expertise to deliver care in a remote setting. So by simply partnering them with a technology services provider and providing some training and supply chain advice, they were able to significantly expand their impact in their region with just existing staff.
It's excellent. Excellent advice. What would you want to layer onto that, Paul? What are your thoughts?
Well, I mentioned earlier how this particular study in JAMA found lots of shortcomings, but there are also several high-quality, commercially available telemedicine providers. We don't want to plug any particular one, but there's a long list of services that a hospital or a clinic can buy into if they don't have the IT expertise, and just run with it.
Yeah. No, it's excellent. I love that the thoughts there of expanding the scope of practice, because also you can look at what you're able to achieve as an organization, and maybe strategically what do you want to achieve, because it's almost like you can reinvent yourself in some ways. And how can I best serve my community? And now through technology innovation and partnerships, you might be able to do a lot more than you ever thought in just a traditional brick and mortar, four walls of what you had.
It really is a reinvention.
Yeah.
That's the right word for it.
I love it.
And here's a way, I guess, Justin, to think about it, which is today, and of course I'm making this up, so this is a rhetorical question. How many times a year do you see your primary care physician? Oh, once for the annual, maybe twice a year.
You got it.
Well, great. But what happens in between those 1 or 2 visits?
Right.
And wouldn't it be actually, as we think about healthcare and wellness going forward, to go from episodic healthcare to continuous healthcare? What if algorithms looking at the devices in your home or the devices that you wear could say, oh, well, I've actually detected a material decompensation or change in your condition, and now we're going to intervene just in time, as opposed to waiting for 6 months from now for that next doctor's visit. And that's the reinvention.
That's excellent. Excellent. So, and I do want to touch on devices here in a moment. Before we do that, let's talk about the new initiative that you mentioned, the hospital at home. I've read this a couple of times. I've certainly seen this out there a little bit, but tell us about the advanced care at home.
Well, so here's the simple answer. If you can take a serious and complex illness with the right patient monitoring, the right remote expertise, the right supply chain, the right in-home help, shouldn't you be able to deliver the same care plan, the same medications, and the same outcomes as a bricks and mortar experience? And no one was quite sure. And so we, with extraordinary diligence, started very small and then studied everything from every encounter and moved fast and thought big. And so as of now, we've discharged over 200 patients that are serious and complex using this approach with equivalent quality, equivalent outcomes, reduced cost, and much higher patient satisfaction.
Yes.
Because you stayed at home with your pets and your family and your bed and your food. And really interesting, very common for the elderly when you move them into a hospital setting to sundown, get a little confused as nightfall approaches. What we saw in a home hospital approach, no sundowning, because you never leave that familiar environment. So lots of interesting benefits.
Did you see this evolve more quickly because of COVID or with COVID? Did it help you in some way move this initiative forward faster?
2 ways. So first, what we found was, especially for those who are immunocompromised, they actually preferred to get their acute care outside of a bricks and mortar facility purely to avoid contact with those who might be infected. So that was good. But the other way, during the surges, you actually start across this country, saw ICUs and ward beds hitting capacity. So it allowed us that surge protection, so to speak, of being able to admit patients into their homes and see 20 more patients in an inpatient setting than beds were available in a community. Worked really well.
Wow. That's excellent. What are your thoughts, Paul? What would you add to that?
Yeah, I recently had a conversation with A.J. Dunn, who is right in the middle of this advanced care at home project. He's one of the administrators there. And he brought up a couple of interesting points. One of them, he mentioned that the hurdles that they have in dealing with insurers. Because when you approach a typical insurer, they don't have a model for hospital at home care. So it's like, where do we place this in our portfolio? So what they've had to do is go one by one with each insurance company to explain the cost effectiveness of it, and that's how the program is advancing. And the other thing that he talked about was there's something in their system called a syndrome sniffer. So it's a tool, a digitally enhanced tool to help with detecting or spotting patient deterioration early on, which is something that is often missed in a hospital setting. So those 2 things really stood out in the conversation that I had with them.
That's excellent. That's excellent. For those just tuning in, we're speaking with authors Paul Cerrato and Dr. John Halamka about their new book, The Digital Reconstruction of Healthcare, Transitioning from Brick and Mortar to Virtual Care. And you've heard that theme over and over now, which is excellent. So diving in here, how is voice technology having an impact on diagnosis of heart disease and neurologic orders? Paul, do you want to start off there? Or?
Yeah, some of the interesting projects that are going on at Mayo Clinic. It's possible to take voice samples and analyze them for emotional content. So one group of researchers asked for patients to provide a positive and a negative emotional experience. And what they found was that the negative emotional experiences were more common amongst people who were likely to eventually develop heart disease. And the rationale behind it is probably the negative emotional experiences reflect some sort of change in the adrenal system, which in turn, everybody knows the connection between stress and heart disease. So taking samples of the voice is one way to help predict the onset of heart disease.
Wow, that's fascinating.
It is.
Well, or Justin, let me give you a couple other examples. So imagine that you have a change, not in the content of your speech, but in the tone and the amplitude. Can you, through an AI model, detect neuromuscular disease like Parkinsonism or Lou Gehrig's disease, ALS, through changes in the way you speak? And the answer is yes, with actually a high degree of certainty. And those algorithms, which Mayo is polishing up now, you could imagine. I mean, this is going to sound like a little bit far-fetched example, but you could say, hey, Alexa, I am concerned about changes in my speech, to which the response would be, well, we believe that you should be evaluated by a professional, and we are going to refer you to an appropriate professional. Because the algorithm behind the scenes has detected that there is, in fact, a correlation with a developing neuromuscular syndrome.
Wow. Yeah, I can really see this, certainly with Alexa and other voice-enabled technologies and innovation. So that's awesome. I love it. And I'm sure most of my listeners have not heard that before, so it's pretty fascinating. So let's dive in a little bit, because you brought up medical devices and wearables now a few times, and also in our previous episode. I know you guys have really studied some of the cybersecurity and the risk there. So do you want to start off and highlight some of that, John?
Sure. So what does IoT stand for? Internet of Targets.
That's good.
Right? So here we are taking these devices that have maybe very little security protection and connecting them to our computers and our home networks. And I'm sure you remember, Justin, just not so long ago, Home Depot had a major hack. Sure. And how did they get into Home Depot? The air conditioners. What? Well, it turns out air conditioners had thermostats that had IP connections and very little security protection. And so this is absolutely critical, that as we look at the new connected devices in healthcare, that we are paying attention to cybersecurity risk. Dr. Kevin Fu was just appointed as the FDA's first lead of their cybersecurity efforts. And his role will be to publish the guidelines and best practices so that manufacturers and users understand how to minimize risk.
Is there a time frame there? Do we know? Is it next 12 months, 18 months? So they've wrapped a time frame?
Well, of course, I can't speak for what the government is likely to issue in terms of
right.
regulatory guidance. But Dr. Fu has been working in this area for more than a decade.
Okay.
And I have a feeling that he delivered grand rounds last week at Mayo Clinic. Okay. I have a feeling that he is going to work quite rapidly to give us all a set of best practices.
Excellent.
So that we recognize that we're as strong as our weakest link, and many connected devices are pretty weak.
You got it. And it's just good also to be reminded of this, because, we could see that today in numerous areas of our lives, but certainly healthcare is critically important to all of us, or at least it should be. So looking forward to mitigating those. What would you add to that, Paul, or your thoughts there, Paul?
Yeah, John talked about we're as strong as our weakest link. When you dive into some of the devices and the operating systems that they use, weakest link doesn't even describe the problem. Some of these devices still use outdated Microsoft OSs, systems operating systems that are no longer supported by Microsoft, which means they're no longer supported. You no longer get the security patches that you need. Some of the devices are come with a user's manual, for instance, and that user's manual is easily available on the internet for any hacker to get. And oftentimes these devices have a default password, so it might be 123 John.
Right.
And anybody who opens up the user manual knows what that password is. And oftentimes the hospitals never change the password. So it's an invitation. It's an invitation.
You're right.
Unless you think that what Paul has said is rare, you probably saw in the news in the last 2 weeks a small municipality had its water system hacked.
Sure.
And was this because they had a nefarious skilled hacker? No, it's that they didn't change any of the passwords and all the passwords were the same.
Yeah, exactly. And so my follow-up question was going to be best practice to mitigate some of these risks, but I think we just came across the simplest best practice is to change passwords and create unique passwords.
Well, but how about this, Justin?
Yep.
Multi-layer defense. So what do I mean by that? Well, tonight you're going to go out grocery shopping. Will you wear one mask or two? Will you wash your hands before and after? Will you bring a sanitizing wipe? And the answer is, oh, yes, of course I'll do all of those things. So if any one of them fails, you have backup protection.
Correct.
And security is the same sort of approach.
Excellent. Sage advice. So coming into our final moments here, let me see, we've got about 4 minutes or so. Let's talk about some of the misinformation problems in healthcare. So who'd like to start off there?
Let me start off.
Yeah.
This is another one of those topics that is very dear to my heart and also very irritating. Mm-hmm. There's lots of misinformation out there. I have a background in nutrition, and there are all sorts of quack nutrition cures that people are claiming, and there are cures for COVID and so on and so forth. So how do we deal with them? It's easy for us to take a holier-than-thou attitude because of our training in healthcare. A physician maybe has 12 years of training. I've got graduate school training. It's easy to say, well, we know better than everybody else. But when that tone comes across, it really turns off the public. Mm-hmm. I come from a working class family. I was the first person in my family to have a college education. And I always get the sense that all my working class relatives think, you think you're better than everybody else. The point being, when we deal with people who have been misinformed on healthcare, we have to respect their views, we have to have patience, and we also have a willingness to admit that sometimes we're wrong, even though we have all the education and experience. And each time we do that, I think we get a little closer to developing a trusting relationship with people who doubt healthcare and healthcare expertise.
And to just amplify what Paul said, so I went to medical school in the early 80s. And that means about 50% of what I was taught was wrong. I just don't know which 50%.
Right.
And so one has to be very humble, and one has to constantly look at emerging evidence. And then, based on data and evidence, work with the patient to make a decision that is respectful. And that's how we overcome misinformation.
That's excellent. Excellent. So we'll end with one final crystal ball question. On our last episode, you talked about the advent or with the evolution of home diagnostic devices, or at least the proliferation that we'll probably have in the coming months and years in healthcare. But what else would you say, John, looking into the crystal ball of the next 12 to 18 to 24 months in healthcare? What should we be looking out for or expected to see?
Well, I think just more broadly is this change in healthcare models that we talked about in this episode. And that is that we'll move from the bricks and mortar, I drive once or twice a year, to the continuous monitoring and interpretation services. So in some ways, I could argue that healthcare systems will become data companies, and that they will offer their services to keep their patients healthy in their homes, as opposed to see them once or twice a year when they're sick.
It's excellent. We got about 30 seconds. Anything you want to mention in there, Paul, from your crystal ball?
Yeah, truth is stranger than fiction. You hear that a lot, but it's also harder to recognize. So most of our conversation is about how to recognize the truth when it comes to AI and machine learning. I think over time, docs are going to become more savvy, more discerning, and better able to recognize truth and separate it from junk science.
That's excellent. I agree. And to plug the book one more time, The Digital Reconstruction of Healthcare, Transitioning from Brick and Mortar to Virtual Care. So when will the book be launched? Is there a time frame, the dates?
We just finished the last chapter, so I'm guessing probably sometime in the second quarter. And it's coming out from Francis and Taylor.
Yep. And in conjunction with HIMSS? Is it in partnership with HIMSS?
It's part of the HIMSS book series, yes.
Excellent. Terrific. Well, hopefully, and HIMSS will go off this year. I know we're still looking out there. We've been talking about it on my shows, and I'll continue to have a lot of the HIMSS leadership through my show here in the coming 6 months, and hopefully in prepping for a great HIMSS 21 annual conference. And hopefully I'll see you gentlemen there, if not in person, then virtually, as always.
And I'm already signed up, so see you there.
Terrific. Excellent, John. Gentlemen, thank you so much for joining me today. You always are wonderful guests. I look forward to our next chat, as we always have these on a regular basis. And thank you to everyone for joining us. And please tune in weekdays at 2:30 p.m. Eastern, 11:30 a.m. Pacific. As always, you can track me on Twitter at HIT Advisor and use the hashtag ThisJustinRadio so we can respond to your comments from the show. If you missed any of this episode or want to hear more, all my shows are posted at Apple iTunes, SoundCloud, iHeartRadio, Spreaker, Google Play, and TuneIn. You can check out the new content we posted on justinbarnes.com as well. Thanks, everyone, and stay safe.